Good afternoon, everybody. Welcome. Today I'm going live with Gainam Fertility Clinic, who are based in Prague, and we will be talking to Dr. Kristýna about the impact of IVF over 40. What does that mean in terms of egg quality, treatment options, and also, importantly, success rates? So if you have any questions for the team, please have them ready. Welcome to those who are joining. We will be going live shortly with Gainam Fertility Clinic based in Prague to talk about IVF over 40. We've had many questions around this and written many articles. The link is in our bio to read more from the team and also to get in touch with their team once we've spoken. So hi to those who are joining. Nice to see you today. Please have your questions ready for Dr. Kristýna. Hello, good afternoon.
Hello.
Welcome.
Hi.
How are you?
I'm fine, thanks. And you?
Good, yes, very well, thank you. Please do introduce yourself and the fertility clinic. I've just given you a brief introduction, but it would be lovely to hear more about your role at Gainam and also the people you help around the world, and then we'll talk about IVF over 40.
Okay, so my name is Kristýna Fruhaufová. I'm the head physician in the Gainam IVF. We are like a middle-sized IVF clinic based in Prague. We run over 800 to 9,000 cycles of IVF per year. Half of our clients come from abroad, so it's like 50% Czech-based clients and 50% mainly from UK, France or Germany.
Great. Today we're going to talk about IVF over 40, and we do have a lot of readers and followers who are looking into treatment, over sort of 35 and beyond, and it's really good to understand treatment protocols, success rates, and things to consider when starting IVF or resuming IVF around this sort of age. So first of all, for people who may not be aware, what is the impact of age on fertility?
Actually, the age is the main factor that plays the role in the IVF success rate because women, we are born with certain capacity of eggs and we are just running out of them through our fertility lifespan. So it means that when we are in our mother's womb, we have the highest number of eggs, and by the time that we are born, they start to diminish. So basically, it's like there are different factors. We don't know yet which one is the most important one, but overall, it's like that the best quality eggs come usually first when you start having your period, so when you're young. And also over the age, there's a likelihood that you will accumulate some DNA damage. So with that altogether, well, generally in women over the age of 35, there's higher rate of chromosomal abnormalities in the embryos later on.
Okay, really good to know. If anyone has any questions as we're chatting, please feel free to ask. It's very kind of you to give us your time today. And in terms of IVF process for women over 40, is this any different to women, say, under 37, for example?
Yes, it is, because as I mentioned, the capacity is running low, so you have less eggs to work with, and also you have higher chance of not having good quality embryos. So basically, to be successful, you need more eggs, which is difficult to get when you age. So to get a chance to have a healthy baby in the end, for example, in women above the age of 40, we know that we need at least 8 embryos for one healthy child.
Wow, interesting. And what about for people who are 38? What's the difference between 38 and 40?
Well, the fertility in women generally drops after the age of 35, but we're all different, so we all vary. So some of us are more lucky to have higher ovarian capacity, some on the other hand are not that lucky, so you never know in advance. So generally the first breaking point is 35 years of age, and then the fertility starts to drop very low after the age of 40. So generally between 35 and 40, still the chances are quite high.
Okay, but then you see a significant decline from 40
Yes,
onwards.
yes.
So you mentioned you would want to have 8 eggs, or did you say 8 eggs?
8 embryos.
8 embryos for the chance of one child over 40. So how many embryos would you hope to have for someone between 35 and 40?
Well, we're talking not. There's a difference between embryos and blastocysts, so we should be more specific. So we need 8 blastocysts in women over 40, and below that, it's something between 5 to 6.
Okay, it's quite a lot, isn't it? And I was going to ask, is it, for women who are in their late 30s, over into their 40s or early 40s, do you ever see cycles where none of the embryos make it to blastocyst stage?
Unfortunately, we do. It's all about the number of, and also the quality of the eggs, which is defined by the age. But the more the eggs we can yield from the stimulation, the higher the chances of having a good quality blastocyst in the end that will lead to pregnancy.
Do you ever do, at Gynam, do you ever do transfers on day 3?
Sometimes we do. Basically, doing the blastocyst transfer is good when you have more embryos developing. So when you want to wait and see which one is the best for the transfer, when you have only one in the development, it doesn't really make sense to wait until the blastocyst stage. So in that case, we sort of talk to the couple, see what are their preferences, and when they decide to do the day 3, we do that. But we never transfer before, so we don't do like day 2 transfer.
Okay. Because I guess from day 3, that's sort of naturally when the embryo would be reaching the right place in your body, right?
Well, from the point of view of like the embryonal development, between day 3 and day 4 is the first milestone for the embryo, because up to day 3, the embryo only lives from the energy that's been given from the egg. And from day 4 onwards, when the DNA of the sperm is well integrated as well, the embryo switches to the embryonal metabolism and starts to produce its own energy. So it's like the first crucial step the embryo has to make. And the implantation process itself will be happening later on. The embryo will implant by day 6 to 7 anyway. So it will stay in the uterus.
They're advised not to test early, right? Because the embryo may have not had a chance to implant yet.
Exactly. So regardless what day you do the transfer, the embryo will implant later on.
Interesting. And in terms of egg quality, is there anything that women can do to increase it, especially in late 30s and early 40s?
Unfortunately, not yet. There are lots of agents that have been tested over the past years, like androgens. There's a lot of supplements that you can actually buy, but they haven't been proven to work yet. So it's you can imagine that the DNA in the egg is in like very unstable state until the egg matures. So you have a lot of proteins. You can imagine the proteins as, for example, a fiber that is covering the DNA. And over the age, it just wears out. So we are dealing with a damage that we cannot mend by giving any medication or anything like that. So we are just not able to reverse the aging process. So
about focusing on a healthy lifestyle.
Yes, that's one thing that you can do as a prevention. So if the woman is a non-smoker, she's been on a healthy, reasonable diet, she's not overweight, it all adds up. But it's not something that you can do as the last resource or the last step to save your fertility. You have to accumulate those good things over your lifetime to see some or to yield the effect later on.
Absolutely makes sense.
Yeah.
If anyone has any questions for Dr. Kristýna whilst we're talking, please do feel free to ask. I have some more questions.
Yeah.
IVF success, what does that look like in terms of percentages, depending on how old you are?
So when we start with the age category between 35 to 40, the success is around 30, 25, 30%. Then after the category between 40 and 42, still we're looking at some quite good numbers, like around 20%. But after the age of 42, it starts dropping even down to 5%.
And how does that compare to people who are younger than 35, for example, between 30 and 35?
Well, I think that the overall numbers around the world from the IVF around 40% chances. I'm just talking about one transfer. So when you have more embryos, then you have a so-called cumulative success rate, which means that it goes up with each attempt of embryo transfer. So this is like the success rate per one embryo transfer.
Mm-hmm. And at GoNam, do you transfer two embryos?
But generally, we are trying to do this.
We seem to have a fire
Yeah.
alarm going off in the office. It should stop any second.
Okay. So should I wait or?
Yeah, it'll
Yeah,
be
yeah.
a second, I think. There we go.
Okay,
Sorry
good.
about that,
Okay, that's
everybody.
fine.
Please do repeat what you were just saying.
Well, we tend to transfer just one embryo in most of the patients. Generally, the policy is that in women, when you have failed cycles, or in women with higher age, you transfer two embryos. But when you have a good quality blastocyst, we tend to do a single embryo transfer to reduce the likelihood of having twin pregnancy.
Even for patients over 38, for example?
Well, in that case, we would do a double transfer.
You would?
Yeah.
Well, at what age would you start doing a double transfer?
Well, it's hard to generalize to say it for all the population.
Yeah.
Mainly, as I said, I would do it for a patient that has already had and failed transfer.
Yeah.
And well, it's generally like women 38 plus that we advise to try or consider the double transfer. But you have to consider the medical history of the patient as well, because you wouldn't do a double embryo transfer to a woman that has had any surgery on her uterus, for example, the previous C-section, or she has had a myomectomy or things like that. So
you wouldn't do a double transfer on someone who's had a C-section?
Well, I would talk to the patient and advise her on the possible risk, because when you've had a C-section, it means that you have a scar that even if it was fully healed, the tissue is not functioning as the non-scar tissue, so it's not fully functional myometrium. So in that case, you have a risk of the rupture during the pregnancy. And when you have a twin pregnancy, the uterus enlarges and you have a higher risk of any pregnancy complications. So if the patient agrees, then we would do a double transfer, but mainly we would try to talk her out of it.
Makes sense. Do you see a lot of patients who have come back for potentially another child who have had a C-section before?
Well, actually we do, because generally the older the woman, the higher the likelihood of any pregnancy complication or complications during the labor, so they're more likely to have a C-section. So yeah, we see that giving a birth through a C-section has been more frequent over the last years.
Mm-hmm. Interesting. I have a couple more questions,
if
that's okay. I want to ask you, we talked about success rates. Do you recommend any tests such as PGTA for women over 40?
Well, not routinely, to be honest, because for the PGTA to make any sense, you have to have enough embryos to test. So first of all, it costs a lot of money. Yeah. You pay double the price of the IVF cycle, so that's one thing. Second thing, it won't mend the embryo. It's just informative to tell you about the chromosomal status of the cells that have been biopsied, which means that you're taking only small samples of the cells within the embryo, and it doesn't have to be fully representative of the remains of the embryo. So we have to be aware of the fact that it's not 100% accurate when you do the PGT testing. So, for example, if I had a patient that I see a chance that with the stimulation she would produce, let's say, 10 to 15 eggs, which means that in the end we would end up with 5 to 6 blastocysts, then there is a chance of having a good quality and healthy embryo after the PGTA. But doing the PGT testing to just 1 or 2 embryos doesn't make sense to me.
Is that because you would either transfer the best looking or you would transfer 2 potentially?
Yeah. And sorry, when you have like a non-euploid embryo, it won't most likely implant. So you're not like putting the woman at high risk of anything. So
is there a risk of PGTA causing damage to an embryo?
well, we try to do it as safe as possible, but you never know how the manipulation with the embryo may impact it. Well, there are lots of epigenetic changes that may be done with any manipulation. So we don't really know has the long-term impact because the PGT testing hasn't been done for many years. So you don't have a long-term follow-up on the infants born after that. So definitely we are doing something to the embryos, but we don't know yet.
Yeah. And I was also going to ask about PGTA. There's a wait, isn't there? So you can't have a fresh transfer.
Yes. You have to freeze the embryos and wait for the result, and it usually takes about 2 to 3 weeks. So you sort of like skip one cycle. There is also, sorry.
I was just going to ask, is there any difference in success rates between frozen embryo transfers and fresh IVF transfers?
Actually not. So when the lab is working well and you have well-working freezing process, the success rates are the same. And it's actually one thing that is quite interesting, because when the PGTA was introduced over the last, I don't know, 10 years, so 10 years ago, the idea behind was that the success rates will go up a lot, but they didn't. So you still keep the same success rate even if you're transferring euploid embryos. So yeah, well, still we think that there's a lot of things that we don't know about the embryonal development, and the embryo has huge capacity to heal itself. So if there is like a even partial part of the cells that are normal and euploid, they should be able to recover and keep on dividing and lead to a healthy child.
So I guess that's also something about PGTA, isn't it? That you may potentially, through doing PGTA, discard an embryo that could have been successful transferred.
Yeah. There are a lot of ethical questions around PGTA actually that we still don't have the answer to them yet. So right now, even within our like IVF community, the PGTA still remains questionable whether it should be offered to the patients or not.
Absolutely makes sense. And for patients who might be a little older, so in the bracket that we're talking about today, but they might be using embryos that they created when they were younger, is that something? Does that sort of mean that their age at the time of transfer doesn't matter so much because the embryo was from when they had younger eggs?
Well, what makes this most important part of success rate is the age of the eggs, actually.
Yeah.
But still, the uterus itself is aging. So you have all the vessels that are functioning differently when you're 20 and when you're 40. So there is some impact of the uterus itself, but it's not that strong as the age factor of the eggs. So you may overcome, let's say, the age of your uterus by using younger eggs.
Okay. And is there an increased risk of miscarriage and chemical pregnancy if you're slightly older?
Well, we see some pregnancy-related complications that are more often related to the age. So yes, the risk of the miscarriage is slightly higher. There's also a bit higher risk of preeclampsia, which is linked mainly to the quality of the placentation. So it means that how deep inside the womb vessels the placenta is being introduced during the early pregnancy. So to ensure enough blood flow in the placenta and make the placenta fully functional, you need like deep placental invasion in the womb.
Interesting. This is fascinating. Thank you. If a patient has had an unsuccessful cycle and they are concerned about their age, what would your recommendations be for treatment plans and next steps?
Well, generally in older population of women, I don't want to touch anyone, but still, you know, the reproductive lifespan in women is something that is well defined and we can't beat. So it's mostly like the wait for the good quality embryo. So just repeating it all over and over again, that's one thing. If you still have a chance to get enough eggs with the stimulation. There's also the question of using the oocyte donation. That's another thing. But
yeah. And do you give increased protocol medications to women who are older? So would you give them a higher dosage of fertility drugs?
again, it depends. It depends on whether you have a chance to succeed, because sometimes decreasing the doses when you have a woman that you know that she only has like 2 follicles on each side doesn't really make sense, because even with giving her high doses, you just put her on risk of any side effects during the stimulation. So it's really individual. You have to, you know, as I said, each woman is different. So it's not that you have like overall one protocol that you would use in women over 40 years of age.
Yeah, that makes complete sense. Well, thank you so much for your time. I hope everyone has found it useful as me. I've learned a lot today. And please do head to our link in bio to book a consult with the team at GNM, who are very happy to help you with a personalized plan, to discuss options, anything around what we talked about today, or any other question that you might have. So thank you so much for your time. It was a pleasure.
Thanks a lot.
To see you, and we'll see you very soon.
Bye.
Thanks to those.
Have a nice day. Bye-bye.
Bye-bye. Bye.